think we are live. Yes. All right. Good evening to all the viewers. This will be the discussion session of the Monday midday quiz. The topic for this Monday midday was cardiomyopathies. And this was an integrated exam between medicine and pathology. So we'll have an integrated discussion as well. So with me, I've got Dr. Vandana Puri, Madam, the pathology faculty. And Madam will be discussing the pathology questions of this quiz. And, I'll be discussing the medicine part. But again, we cannot put a delineation into medicine and pathology because, seeing the trend of questions, these are all integrated questions. And these questions will have high yield, not just for your INI-CT, but for your NEET PG exams as well. And also, let me tell you at the outset that this is not going to be a detailed test and discussion type of session. We'll try to keep the answers more precise. And the objective is to, for the students who have taken the exam, we are trying to guide them and correct whatever mistakes have happened during the exam. So let's start the discussion. Welcome, Vandana ma'am, to the session. Thank you so much.
Thank you so much, sir, for just organizing this type of quizzes. And I think these type of quizzes are the much want of time, because these are the type of questions that are basically coming in your INI-CT and NEET PG, and obviously I think this basically helps in increasing our horizons also to understand the question in a better way, because once you know the pathology and then you know the medicine, you know what's actually going on and how to treat the patient, and that's the final, the motive.
Right. So I think, ma'am, we'll start the discussion.
Yeah. So starting with the first question. So the first question was match the following type of question. So this was basically kept to understand the genetic basis of the cardiomyopathies, guys. So whenever we are looking at this question, I am sure all of you would have been able to solve this question. But just to tell you that whenever we are talking about cardiomyopathies, you have to understand a basic diagram which is given in the Robbins. And the very basic diagram is that whenever there is a defect in the force generation, that is very classical of HOCM. Okay, so that is why HOCM, hypertrophic obstructive cardiomyopathies, usually have force generation problem, with a major defect being in myosin binding protein C or beta myosin heavy chains. So whenever these are defective, the sarcomere itself cannot produce the force. Okay, so remember always HOCM is a dominant negative kind of inheritance. What does this mean? That whenever there's a defective protein in myosin binding protein C or beta myosin heavy chain, what is going to happen is the normal sarcomere is not formed. Okay, so because of that, the other proteins try to compensate it by undergoing hypertrophy, and this abnormal protein will not let proper sarcomere functioning. Okay, so that is what is going to happen here. So that is HOCM. Now, whenever the force transmission is a problem, this is a typical feature of dilated cardiomyopathy. Okay, so its inheritance varies. So most common inheritance of dilated cardiomyopathy is in the largest protein defect, that is titin mutation. So titin is one of the largest protein, and whenever it is defective, it doesn't transfers the force from the sarcomere to the extracellular matrix. So this is the most common type of inheritance in dilated cardiomyopathy, and it is autosomal dominant in inheritance. Okay, or there can be defect in the mitochondrial proteins, in the beta oxidation defects in the mitochondrial proteins. And when mitochondrial proteins are defective in fatty acid oxidations, these usually cause dilated cardiomyopathy in pediatric age group. Okay, in the pediatric age group. Whereas whenever there is a defect in dystrophin, okay, so again the force is not being transferred to the extracellular matrix, then it is inherited in X-linked recessive manner. So remember, the transmission of force is defective, and depending on which protein is defective, which gene is defective, the mutation varies. So titin is autosomal dominant, dystrophin is X-linked recessive, and mitochondrial is in pediatric age group. Okay, so now looking at the question here, so this is titin gene, and all of you know that this typically causes autosomal dominant dilated cardiomyopathy. So first is D. C. So you can rule out the other options. So we are left with C and D. Now next is dystrophin. You know, dystrophin is X-linked cardiomyopathy. So 3 has to be C. So now we are left with third option here. Okay, so we know third is the option, but we'll still check. Okay, myosin binding protein C is defective in HOCM. We know that 4 has to be B. So this is correct. Now we are left with ATTR. All of you know ATTR is a type of amyloidosis. Okay, so whenever amyloid deposits in the heart, it causes restrictive cardiomyopathy. Okay, so that is 5 is A. We know that. Now, what is this tafazine? Okay, so tafazine is a very important gene which you have to remember. So remember, this can also be associated with X-linked dilated cardiomyopathy. But what is the catch point here is that it typically causes left ventricular non-compaction. What does this mean? So to understand this, let's understand this. This is the left ventricle, and you know that whenever there is left ventricle non-compaction, so there is excessive trabeculations which you can see in the endocardium here. So this endomyocardium, there is a lot of trabeculations which you can see, and this is called as left ventricular non-compaction. And this syndrome here, there is a syndrome which is associated with the mutation of tafazine. Tafazine is a protein coded by a gene called TAZ, and this syndrome is called as Barth syndrome. Barth syndrome typically has left ventricular non-compaction with skeletal myopathies and neutropenias. So this is a mutation by tafazine. Okay, so that is an important gene that we wanted to introduce here. So this is tafazine gene which is there. Apart from that, one more important point I want to highlight here is ninja stars, which was an INICT question last time. It's a very suggestive feature of titin truncated mutations. So whenever we have titin truncated mutations in the dilated cardiomyopathy, they have ninja stars. And when do you suspect that? Whenever you see this ninja star nucleus more than 5%, you suspect titin truncated mutations. So that is another point that you have to remember here. So that is what the mutations of the cardiomyopathy that are commonly asked. I hope that solves most of the answers, and I hope you would be clear with this. Second question will be covered by Rahul sir.
Okay, ma'am. So, right. So, I hope my screen is visible, madam.
Yes, sir. Yes, sir.
Okay. So the second question is, which of the following is not an expected examination finding in hypertrophic cardiomyopathy? So what are the options? Number 1, pulsus bispherians. Number 2, wide S2 split. And option 3 and 4 are 2 murmurs. So let's look at the options. Number 1, pulsus bispherians. So the first one is an expected finding in hypertrophic cardiomyopathy. The point you have got to remember is that in case of bispherians pulse, so bispherians means bi means 2. So there are 2 peaks in systole. You can see that there is the percussion wave as well as tidal wave. As an additional point, I want you to know about 2 patterns of bispherians pulse. Now you can see this is pattern 1 of bispherians pulse, pattern 2 of bispherians pulse. In both these patterns, you can see that there are 2 peaks in systole. Okay, both are abnormal and both are pulsus bispherians. Now, how are they different from one another? You can see that in pattern 1, both these peaks are almost of the same amplitude, that is percussion wave and tidal wave. Whereas in the pattern 2, you can see that the second subsequent wave, which is the tidal wave, it is not as that amplitude as that of the percussion wave. And you can see it is slightly slower in rising as well. So this is sort of a camel hump. And this is the typical type of the bispherians pulse in case of hypertrophic cardiomyopathy. Whereas pattern 1 is the typical pattern in case of severe aortic regurgitation as well as a combination of aortic regurgitation with aortic stenosis. So am I happy with option 1? Yes, it is an expected finding. So I am not going to pick that as the answer. What about the other options? Wide S2 split. So you know that the second heart sound S2 consists of the A2 component and the P2 component. Normally what happens first? It is A2 followed by P2. Now in case of hypertrophic cardiomyopathy, what is the problem? You have got left ventricular outflow tract obstruction. Okay, LVOTO. So what will happen to the mechanical events happening in the left side of the heart? It will be delayed. So what is going to happen? A2 will be delayed. So what will happen to the gap between A2 and P2? Initially, it will be narrowed. So there is a chance that you may get a single S2. And in case of severe hypertrophic cardiomyopathy, you can also have a reversal of the split, also known as paradoxical split, wherein the P2 happens first, followed by A2. So wide S2 split is not an expected finding. What is expected is a paradoxical or a reversed split. So I think I'm going to go with that as the answer, but I'll just have a look at the other two options as well to be doubly sure. So the third option and fourth option, remember, both are murmurs. And in case of hypertrophic cardiomyopathy, remember in my lectures, in the DocTutorials app, I've always highlighted two important types of murmurs in hypertrophic cardiomyopathy. The first one being the mid-systolic murmur or the ejection systolic murmur, which happens because of the left ventricular outflow tract obstruction, and this is heard in the aortic area. Now, can you get a pansystolic murmur in case of hypertrophic cardiomyopathy? You can. Is it common or less common? It is less common. Then which murmur is more common? It is the mid-systolic murmur that is more common. And what is the reason for pansystolic murmur? This is because of the systolic anterior motion of the mitral valve leaflet resulting in a type of mitral regurgitation. Okay, so all these are expected findings except option B. I hope you are clear with that question. Let us move on to question number 3, and Vandana ma'am will be discussing.
Yes, sir.
Yes, ma'am. Your screen is visible. Your screen is visible.
Perfect, sir. So we'll go to the third question now. So the third question here is, based on the microscopic finding, choose the correct combination. So this question, basically, I had given you to identify the simple stains which you use in heart and the blood vessels. So there's a lot of confusion among the students when we talk about the stains, when we use it, what we use in heart and the blood vessel. So remember here, what catches your eye is your myocyte disarray. Some myocytes are going like this, some are going like this. So this is a very characteristic finding called as myocyte disarray, which you can see here. That means there is a disarray in the myocyte. And what happens to the space which is left in between? Okay, so if the heart muscle fibers are cross-linked like this, what happens to something which is this? What happens to the space in between? So this space has to have interstitial fibrosis. So there's a lot of interstitial fibrosis which occur in HOCM. Okay, and how do you identify this interstitial fibrosis? Is with the help of mass and trichrome. So can you see here, the muscle is red in color and the collagen is blue in color. So basically this not only helps you to identify the haphazard arrangement of the muscle, but it also helps you identifying interstitial fibrosis, which is blue in color. So this is a mass and trichrome stain showing you HOCM. Apart from that, what are the other stains? Guys, remember, whenever I'm talking about, before we go to the further stains, just remember a few points about HOCM that they commonly ask in exam. So HOCM is very classically characterized by the massive myocyte hypertrophy, which is more than 40 micrometer. Remember, the normal myocyte size is about 15 micrometer. The second is myofiber disarray, which is very, very characteristic, and this can be seen in the electron microscopy also. The third is there is a fibrotic narrowing of the small intramural arteries. And the fourth important is interstitial fibrosis. That's a characteristic feature of HOCM, which everybody should be clear about. Okay. Now, when we talk about other stains which are used in the heart and the blood vessel, this is the next stain which you have to remember. This is elastic fibers. Okay, so elastic fibers are identified by a stain called as von Giesen elastic. Okay, so von Giesen elastic. Okay, so VGE, or this is also called as Verhoef's von Giesen stain. Okay, so Verhoef von Giesen or von Giesen elastic are both similar stains. Remember, And this is a silver stain. So wherever you see that black fiber, this is a silver stain. And can you see that normally this is like a linear oriented elastic fibers, because they are parallelly arranged so that they can provide the elastic recoil to the larger vessels. But in this case, is what you see is what catches your eye is that these elastic fibers are degenerated, and wherever there is a degeneration, usually there is cystic spaces which are there, in which some mucopolysaccharides can fill in. Okay, so this is what is called as cystic medial degeneration, which is seen in Marfan syndrome, and this was your NEET PG question this year also. So cystic medial degeneration is seen in Marfan syndrome. And how do you identify this? You can identify this with Verhoef's von Giesen or von Giesen elastic stain. Please remember, there's another stain here which was given in the question. This is reticulin stain. Please remember, reticulin stain helps in identifying collagen. Okay, so this is basically for identifying collagen. Okay, especially collagen type 4 is identified by reticulin stain. Okay, 3 and 4 basically. And it identifies not only this is a liver biopsy. So it identifies not only the framework of the liver, but it also identifies the presence of cirrhotic nodules. So you can see the framework as well as nodules. Both are picked up by reticulin stain. Whereas when I'm talking about Masson trichrome can only pick up collagen type 1. Okay, so because it can pick up only collagen type 1, it cannot identify the normal framework. Okay, so it can only identify the fibrosis where it is occurring. That is why in cases of liver biopsies, reticulin is preferred, because it not only identifies the framework, so it identifies collagen type 3 and 4, so it identifies both framework as well as fibrosis. Whereas Masson's trichrome will usually identify collagen type 1 predominantly, but it can identify collagen 3 also, but predominantly collagen type 1, so it can only pick up fibrosis. So these are some basic stains which you should understand. So this is reticulin stain, and Masson trichrome is a stain for collagen. Verhoef's von Giesen is a stain for elastic fibers. So do not confuse in these stains, because they have to be known well, because reticulin and Verhoef's von Giesen both are black color stains. Okay, so that is one thing that you all should be very clear with. Okay, right. So next question will be discussed with sir. So yes, Sonal, I have heard your point, and I will discuss that.
So moving to the next question, choose the false statement about restrictive cardiomyopathy. So this is again an important topic, restrictive cardiomyopathy, and I want you to learn all the cardiomyopathies in comparison as well. Okay, and most of the questions are picked up, relating to the comparison between the various cardiomyopathies. And let's have a look at the options. The first one says massive atrial enlargement. Now, this is actually a true statement, because in case of restrictive cardiomyopathy, for example, we take an example of amyloidosis. So you've got the material being deposited in the ventricles mainly, and the atria will try to contract against the stiff, non-compliant ventricles. And what is the response of the atria to resistance? Is it usually hypertrophy or dilatation? It's more often dilatation than a hypertrophy. So in case of restrictive cardiomyopathy, it can produce massive atrial enlargement. Remember, this is often massive, much more than other type of cardiomyopathies. So the first option is not going to be the answer, because it is a true statement. The second one says positive Kussmaul's sign. So what is Kussmaul's sign? So we know that normally with inspiration, there should be a minimum 3 millimeter fall in the JVP with inspiration. But if there is no such fall and there is a rise of JVP with inspiration, that is suggestive of Kussmaul's sign. And out of the various conditions that can produce a positive Kussmaul's sign, like constrictive pericarditis, keep in mind restrictive cardiomyopathy as well. So restrictive cardiomyopathy is also a cause of positive Kussmaul's sign. So option B is not going to be my answer. Option C, S4 is more common than S3. Now this takes us to the genesis of the various heart sounds. And we know that the S4 usually happens when there is a forceful atrial contraction against a stiff, non-compliant ventricle. And this is exactly what happens in restrictive cardiomyopathy. And you definitely can expect S4 much more commonly than in case of S3. So that is also not going to be the answer. Now, option D, left-sided heart failure is more common than right-sided. Remember, all sorts of cardiomyopathy, be it dilated cardiomyopathy, hypertrophic cardiomyopathy, they are all presenting with, and also even restrictive cardiomyopathy, they often present with exertional intolerance, usually as the first symptom. And one thing you have got to notice that in case of hypertrophic cardiomyopathy and dilated cardiomyopathy, it is usually a left-sided heart failure that occurs first before the right-sided heart failure. And what is the exception? It is restrictive cardiomyopathy. So in case of restrictive cardiomyopathy, the patient often has features of right-sided heart failure first. So patient may have features of pedal edema, raised JVP, ascites. All these features may dominate the clinical picture in case of restrictive cardiomyopathy, and hence that is going to be my answer, option D. It should have been right-sided heart failure is much more common than the left-sided heart failure. Okay, I hope it is clear. Give me a thumbs up in the comment section if you have understood that, and let us move on to the next question.
Okay. Okay, so talking about the next question. So the next question was basically a little tricky question. So this was a 25-year-old man who died suddenly following gross microscopic finding, which is not the correct statement about this cardiomyopathy. So first point is, what type of cardiomyopathy do you think this is? So what catches your eye here is, this is your right ventricle and this is your left ventricle. And what is happening in the right ventricle is that the wall of the right ventricle here, you can see that it is completely replaced by fat. Okay, so here you have completely replaced by fat. Even in the microscope, you see this is complete fatty tissue. Okay, clear space here. So it's fatty tissue, right? So this is a very classical picture of arrhythmic right ventricular cardiomyopathy. So diagnosis is ARVC is perfectly correct. Okay, so diagnosis is ARVC, that is correct. Now, what is the inheritance of ARVC? That was the question which I wanted to ask you here. So, autosomal dominant form is the most common type. That's correct. So, most common type of the ARVC is autosomal dominant. Remember, the most common mutation of ARVC usually is due to defect in the desmosomes. It's a defect in the desmosome. Please remember, these desmosomes are predominantly present in two organs in our body. One is skin and second is heart. So whenever we look at the defect in the desmosomes, this usually affect heart and your skin. Okay. So when we talk about heart, ARVC is one of the classical defect due to defect in the desmosomes, and the most common mutation here is plakophilin 2. This is the most common mutation in the classical ARVC. Now, the first gene to be discovered in autosomal dominant ARVC was desmoplakin. Later on, now recently, this is the new update. Recently, they have found that earlier it was thought that ARVC affects only the right ventricle. Now we know that we also have left ventricular type of ARVC and biventricular type of ARVC. So whenever they give you a question of biventricular ARVC or left ventricular ARVC, the classical mutation is in the desmoplakin. Okay. Apart from that, there is mutation in desmoglein, desmocolin, plakoglobin, TMM43. So these are other genes which are mutated in ARVC. So for now, you have to remember the most common mutated is plakophilin and it is autosomal dominant. Desmoplakin was also first discovered in autosomal dominant ARVC. Now, there are two syndromic associations with ARVC. As I told you that these are defect of desmosomes which predominantly affect skin and heart. So these are skin and heart syndromes called as cutaneocardio syndromes. Okay. So these are cutaneocardio syndrome. The first syndrome here is Nexus syndrome. Remember, Nexus syndrome is a defect of plakoglobin. It is autosomal recessive in inheritance, and both the syndromes are autosomal recessive. Remember that way easily. cardiomyopathy. And in Nexus syndrome, what happens is there is palmar and plantar hyperkeratosis, so skin, along with woolly hair. Okay, so there is a woolly hair, and along with ARVC, you see fat infiltration in the right ventricle. So this syndrome is very typically called as Nexus syndrome. Okay, there should be no doubt in this. Okay, that's Nexus syndrome, and it is autosomal recessive in inheritance. Okay. Apart from that, we have another syndrome, okay, which has been very recently talked about. This is called as Carvajal syndrome. So Carvajal syndrome is also like Nexus syndrome, that is palmar-plantar hyperkeratosis and woolly hair. It is also autosomal recessive. Now, the classical point is it is associated with desmoplakin mutation. So whenever it is associated with desmoplakin mutation, so desmoplakin mutation, when it is associated with Carvajal syndrome, it is usually autosomal recessive. And in that case, it has biventricular or left-sided ARVC, which is affected. Okay. So if a patient presents with Nexus syndrome-like picture, along with biventricular or left ventricular ARVC, you should think of Carvajal syndrome. Apart from that, these patients can also have pemphigus-like picture. I told you pemphigus is also a defect on desmoglein, isn't it? Desmosome. Desmoglein 3 is more defective than desmoglein 1, isn't it? So they can have pemphigus-like picture also. So this syndrome is called as Carvajal syndrome, which everybody should be clear. So please remember here, so when we're talking about this, so Nexus syndrome is classically autosomal recessive, correct? Desmoplakin is mutation is associated with autosomal recessive inheritance. No. In isolation, desmoplakin is autosomal dominant, but when it is associated with Carvajal syndrome, then it can be autosomal recessive. Okay, then it can be autosomal recessive. Otherwise, most of the time it is autosomal dominant in inheritance. Okay, so the take-home message from this is, so the answer here is D. The take-home message from this question is just to tell you about the inheritance, that ARVCs are autosomal dominant in inheritance. They have fat in the right ventricle. We can have left-sided ARVCs also. We can have biventricular ARVCs also. And Nexus syndrome and Carvajal syndromes are two cutaneocardiac syndrome. And always remember that these patients can have either Carvajal or Nexus syndrome. So Shubham is asking, is an ARVD is mutation plecoculpin because it leads to reduction in the desmosome function diagram? Okay. So ARVD mutation, most common mutation in ARVC is not plecoglobin. As I told you, most common mutation in ARVC is plakophilin 2. So Nexus syndrome is a syndromic manifestation in ARVC, which is due to defect in plecoglobin, and all these are desmosomes. All of these are desmosomes, and there is a desmosome defect in this. Because of the desmosome defect, these patients usually have cardiac and cutaneous manifestations. Is everybody clear with this? Okay, so that is it. Okay, so that is what you have to remember. So plecoglobin defect is seen in Nexus syndrome. It is also a desmoglein, and when it is defective, it leads to ARVC. Okay, similarly, desmoplakin is also a desmoglein, so it also leads to cutaneocardio syndromes. Okay, so is everybody clear with this? So we have understood the genetics of ARVC and its manifestation. You have to be very, very clear. Okay, now everybody is clear with this? Yes? Any doubts on this? Okay, so if there's no doubt, we go to the next question, which will be discussed by Rahul sir.
Okay, all right. So since Madam has discussed the topic of ARVC, I just want to show you a picture here. Can anybody in the comment section tell me who this is? A very promising young England cricketer who actually had to retire at an early age after he was diagnosed with ARVC. And can anybody answer that in the comment section? Okay. Very promising England cricketer. So I'm just waiting for your answers. Meanwhile, I'll go to the next question. So, so this is question number 6. All the following increase the intensity of murmur in hypertrophic cardiomyopathy except. Now again, it's again a common question. Factors that increase and factors that decrease the intensity of murmur in hypertrophic cardiomyopathy. So what have I taught you? I have taught you that in case of hypertrophic cardiomyopathy, something that decreases the preload, anything that decreases the preload, anything that decreases the afterload, and also factors that can increase the myocardial contractility. So what is common to all these three? All these three factors would increase the left ventricular outflow tract obstruction. So when it increases the left ventricular outflow tract obstruction, it also increases the intensity of murmur. If you look at the options, option A, that is Valsalva minor, option C, administration of nitroglycerin, option D, standing. All these factors are very well known to decrease the preload. And when it decreases the preload, it will increase the intensity of murmur. Whereas in case of hand grip, it will actually decrease the intensity of murmur. And hence, for this question, the best answer is option B. Okay, right. So coming back to the question that I've asked you, I could not see any answers in the chat box. So this is James Taylor.
Is this Ben Stokes?
No, ma'am, James Taylor. Ben Stokes, is playing, right? So James Taylor had to retire early, ma'am, because while he was practicing in the nets, he was having these palpitations. And for a good reason, he was diagnosed with ARVC, because many a times ARVC presents with ventricular tachyarrhythmias, which can result in sudden death. So in case of James Taylor, he was diagnosed the time he had this exertional intolerance as well as palpitations, and he was diagnosed with ARVC, and he has quit playing professional cricket. Okay, right. So we'll go to the next question.
So it's so interesting that small protein defects basically leads to so much effect. So all these genes are simply coding for desmosomes, and the desmosomal defects basically cause these changes. Is my screen visible, sir?
Not now, ma'am, not now.
Just a second. Is it visible? Yeah.
Yes, ma'am, visible now.
So this was a googly question. I'm sure all of you would have answered this question very well. So this was a 53-year-old female with no history of alcoholism or a family history of sudden death collapses while shopping. She has been complaining of increased shortness of breath but refuses to see the doctor. Autopsy shows a 4-chamber dilatation of the heart. Which of the condition is the cause of the disease process? So I thought, let's come out of the genetics of the cardiomyopathy and talk about non-genetic causes of the cardiomyopathies. So guys, 4-chamber dilatation of the heart is very, very classical feature of dilated cardiomyopathy, and definitely a past mutation of Coxsackie virus. Okay, so myocarditis basically is a trigger for dilated cardiomyopathy. So all of you know that whenever we are talking about this, so if you look at this, other options, we already know myosin binding protein C is basically HOCM, and this patient usually has septal, asymmetrical septal hypertrophy. Fibrillin gene is basically Marfan syndrome, doesn't present like this, and Streptococcus pneumoniae doesn't fit here. So remember, the 4-chamber dilatation of the heart is very, very classical of dilated cardiomyopathy, and you can usually see the mural thrombi also, because it's a dilated heart. So it's like dilated, flabby heart. Okay, he doesn't want to contract his lazy heart. He's dilated and relaxed heart. Such lazy person usually gets mural thrombi. And if you look at the microscopy, there is no specific finding. So, but the catch point here is, again, you can see some amount of interstitial fibrosis here. Apart from the hypertrophy, apart from the dilatation, what is the classical thing that you can see here is this blue fibers are basically your mass and trichrome, which shows you basically fibrosis. Okay, so this is usually in heart we use Gomori trichromes. Gomori trichromes basically give a different counter state, but collagen is usually identified as blue only here. Okay, so this is a 4-chamber dilatation, and the question was given to identify the non-genetic causes of HOCM. And all of you know what are the non-genetic causes of HOCM. Quickly, we have myocarditis, we have alcohol, we have childbirth, we have hemosiderosis, and we have supraphysiological stress. So these are the common non-genetic causes of HOCM, which all of you should know, all of you know, actually you all know this, but you have to know. So myocarditis, alcohol, so alcohol also not acute alcohol, it should be more than 10 years of alcohol intake. So, and other toxins like cobalt, you should remember. Post childbirth, hemosidrosis, remember, most commonly causes. So this is not HOCM, guys. It's dilated cardiomyopathy. Okay, sorry for this. Okay, yeah. So apart from that, this is hemosidrosis predominantly causes dilated cardiomyopathy more than restrictive cardiomyopathy, and this is one question which everybody keeps on asking. And then supraphysiological stress also causes a dilated cardiomyopathy. Okay, and Takotsubo is one kind of dilated cardiomyopathy. Okay, so that's a simple googly question. I think we can go to the next question, sir.
Okay, so the next question is based on a cardiac catheterization finding. This is something which we have discussed in the app lectures as well. So the question is, the hemodynamic tracing shown below is characteristic of which of the following disorders? And in the options are the various cardiomyopathies. So when you look at this hemodynamic tracing, please closely observe this ECG, where you can see that there is a ventricular premature beat here. Yes, this is a ventricular premature beat. Now also observe the left ventricular pressures as well as the systemic pressures. For example, here it is the femoral artery pressure. So following the ventricular premature beat, what is happening to the pressures? So you can see that there is an increase in the left ventricular pressure, and there is a abrupt fall in the systemic arterial pressure. That is, the femoral artery pressure is actually coming down, or the aortic pressure also comes down. So you can say that there is a decrease in the pulse pressure as well. Now, this is actually a paradox in comparison with other conditions like aortic stenosis. So this phenomenon, where following a ventricular premature beat, there is a paradoxical fall in the pulse pressure. This is called what? What is this phenomenon known as? This phenomenon is known as broken brow Braunwald Moro phenomenon. Okay, a long name. Okay, Braunwald Moro phenomenon. Okay, so this is this phenomenon, and this phenomenon is characteristic of which one? Hypertrophic cardiomyopathy, and this actually helps to distinguish a condition like hypertrophic cardiomyopathy, which has a dynamic left ventricular outflow tract obstruction, in comparison with a condition like aortic stenosis, wherein there is a fixed left ventricular outflow tract obstruction. So the answer is option B, and let us move to the next question.
Okay. So coming to the, so we just talked about, this cardiomyopathy when we're talking about the physiological stress. Okay. So let's come to the physiological stress cardiomyopathy, that is Takotsubo cardiomyopathy. It's basically a heartbreak cardiomyopathy. Okay. So recently, just to tell you a recent case. So there was a recent case. This So my husband is an anesthetist, and so what happens is, he told me this case that there was a female who came for anesthesia, and she had lost her husband just 1 month back. Okay, and she was very upset when she came to the for the surgery. After surgery, everything was okay, but suddenly her pulses were not there. She just went, her pulses fall down, and we suddenly, when we did the testing, she was found to have Takotsubo cardiomyopathy. So this is a supraphysiological stresses or stress cardiomyopathy. It's a heartbreak cardiomyopathy. Usually occurs in an older women. So this is typically seen in older women, and very important point is the emotional stress is a very strong trigger. Why so? So why does this happen is, there is a heterogeneity of the autonomic distribution in the heart. Okay. So whenever we have excessive adrenaline secretion or excessive physiological stress or excessive emotional stress, it triggers the autonomic system at various levels. So at points, this causes multifocal contraction band necrosis. So this is how the heart looks if you do the biopsy. So if you look at the biopsy, can you see these transverse contraction bands? So you will see multiple contraction band necrosis here. This is a very classical feature of Takotsubo cardiomyopathy. Usually the patient, recovers within few days or weeks, but this is a heartbreak cardiomyopathy, which you should remember. Now, here the option D was just a googly question, which we have already discussed in the starting also. Multiple trabeculation in the left ventricle causing spongy appearance of the apex. So this is multiple trabeculations of the left ventricle, and this we have already talked, okay, in the starting. This is left ventricular non-compaction here, which shows you these kind of hypertrabeculations. So this is not a feature of Takotsubo cardiomyopathy. So again, to just remember, so multiple contraction band necrosis in the heart is a very classical feature of Takotsubo cardiomyopathy. This is also called as octopus trap. Okay, octopus trap, which you have to remember. So typically of elderly women and usually occurs after physiological stress, right?
Okay, so coming to the last question of the Monday midday, which of the following is a risk factor for sudden death in hypertrophic cardiomyopathy? So this is especially important in screening of family members affected by hypertrophic cardiomyopathy, because just like what Madam had discussed, hypertrophic cardiomyopathy is mainly a genetic condition. Okay, in comparison with dilated cardiomyopathy, wherein you can have genetic causes as well as lot of non-genetic causes, which Vandana ma'am has beautifully described. So, which of the following is the risk factor? Option A, spontaneous non-sustained ventricular tachycardia. Option B, left ventricular thickness more than 30 millimeter. Option C, abnormal blood pressure response to exercise. And option D, all the above. Now, I'm sure that all the above option looks very, it looks very teasing, but yes, here that is the answer. All the above is the answer. Now, this is taken from the table in Harrison. In fact, this is almost a ditto question that was asked a few years back in the Central Institute exams as well. So what are the important risk factors for sudden death in hypertrophic cardiomyopathy? Number one, if there is a history of cardiac arrest or spontaneous sustained ventricular tachycardia, syncope, then family history of sudden cardiac death, spontaneous non-sustained ventricular tachycardia, left ventricular thickness more than 30 millimeter. For example, if there is a family member who has suffered a sudden cardiac arrest due to hypertrophic cardiomyopathy, say suppose his son is having on echocardiography a left ventricular thickness of 35 millimeter, this is highly suggestive of an increased risk of sudden death in that particular individual. And also abnormal blood pressure response to exercise. So systolic BP, systolic blood pressure fall or a failure to increase at the peak exercise again is suggestive of sudden cardiac or a risk of sudden cardiac death. So I hope we are clear on the discussion of the 10 MCQs of the Monday midday. And I hope that you all enjoyed the integrated series that we had come up with this time. And we be trying to do a few more sessions like that. And you can keep following, Vandana ma'am's academic groups as well, both in the Instagram as well as Madam has active quizzes in the WhatsApp as well. So this is my Instagram QR code. So you can scan my Instagram QR code. It's the academic page wherein I'll be posting medicine MCQs. So you can scan the QR code. And this is Vandana ma'am's QR code. You can scan the QR code for Vandana ma'am's Instagram page. So Madam actually puts academic updates in that page. So yeah, so I hope all of you had useful discussion today. So Vandana ma'am, I think we'll try to have a few more sessions, especially if there is a demand from the students, which I'm sure.
Yes, sir.
Okay, we'll
So
be.
I think first we should really ask for your feedback, guys. How did you found this? This integrated session. We'll be posting a Google form for the feedback. Also, please do fill up the form. I'll be sharing in all our groups after this. Please let us know how much did you like the session, and depending upon your feedbacks, we will definitely like to do more such sessions. Yes, sir. Before your INSIT and NEET PG exams. So do let us know our feedback. So I'll be posting the link after the sessions in the group, sir.
Yeah. So thank you so much, everyone, for joining. And yeah, all of you can stay tuned to the DocTutorials social media channels as well for the upcoming topic for the next Monday midday as well. Thank you so much, everyone. Thank you so much, Vandana ma'am. It was a pleasure to have you. Okay, so hoping for more.
Thank you so much.
Thank you, ma'am.
Definitely, sir.